we'll be starting with our guest lecture, the keynote address by none other than Erik Martin, who's come from all the way from Belgium, who's our guest for this APO AIOS conference 2025 in New Delhi. And he's been one of the leading cataract refractive surgery practitioner in Europe as well as world across in Belgium. And he's going to talk us today on the new concept of pairing the lenses, and it makes life possible with geometric and geometric plus to give an advantage to our patient in a way they become comfortable in terms in life, having the range of vision which we require for these patients also. Dr. Erik, all yours.
Thank you, Professor Titiel, for this kind invitation to give this keynote lecture. I'm very honored by that. I was also very pleased always to be in India and to be submerged in your very rich culture, and it's always a pleasure to be here. The subject of my keynote lecture today is pairing two light distribution profiles to create peak visual performance. This is my financial disclosure. I'm going to talk about the Vivinex geometric trifocal IOL family, which is one of the latest and greatest in our armamentarium. It is built on the Vivinex platform, which is a very established platform, and it has a non-apodized truncated refractive zone, and only in the middle, the 3.2 millimeters zone of this lens, you have the diffractive design. Outside of that is a refractive design, which makes that in dim light conditions when driving a car and so on, so there is less dysphotopsia and glare. It is fully preloaded, it's hydrophilic and glistening free, and because it's hydrophobic, of course, there are lower rates of PCO. What is unique about this platform is that there are two lenses, very almost equal, but there are some differences between them. You have the geometric, which is available in +10 to +30 diopters in 0.5 diopter increments. This is the same for the geometric plus. It has the same add power for intermediate and near, both platforms, +1.75, +3.5. The A constant is 119, and it is always delivered in the preloaded multi-cert injector, and the recommended incision size is 2.2 millimeters. Now, what is the difference? I said it's almost the same, but there is a difference. The geometric has more light distribution than the geometric plus for far and intermediate, and less for near. So the geometric plus gives more light distribution for near. So, and this is always delivered to the multi-cert injector, which a lot of our colleagues love because it's versatile. And as you can see, my nurse is preparing the lens while I'm finishing the cortical remnant removal. I stabilize the eye with my left hand through the paracentesis, and the lens is delivered in a very controlled way. The haptics will unfold slowly, so you can control it. And with my second hand, I place the lens in the bag, and then you can deliver it in the eye. When it's a toric, you can rotate it very easily. So you can see here that you can have the nozzle retracted, so you can deliver the lens in the bag, or you can the nozzle put forward, so you can only enter the corneal wound for those who want it. You have a screw part for those who love it, or a push part. It's up to you to decide how to deliver this lens in the bag. Now, what is so special about it? It's the pairing strategy, and it's completely different than mix and match. And I will explain to you how it works and which of the difference in quality of mix and match and pairing. So as I said, the geometric give a higher light distribution for distance and near, and the plus for the geometrics more for far and intermediate, and the geometric plus, of course, for near. How does this look like? So the focus curve is almost the same, and the only difference is the light distribution. Here you can see the difference for distance, so more for the geometric, and in the geometric plus group there is more light going for near. Now, how to prove that this is a very good strategy, this pairing strategy? This is a study led by Professor Kaimak in Düsseldorf in Germany, and it was a study performed in 10 different sites, 8 in Germany and 2 in Spain. So what did they do? They put 36 eyes, so 36 patients, both eyes geometric, 52 patients, both eyes geometric plus, and 36 mixing the geometric with the geometric plus. This was published in Clinical Ophthalmology recently in 2024, so last year. And 84% of the eyes showed a spherical equivalent with it half a diopter. So what did this study find? As you can see here, you can see the different defocus curves. When you implant the geometric in both eyes, or the geometric and geometric plus, you have an as good distance vision as only the geometric in both eyes. For intermediate, it's slightly better when you implant both geometric lenses, and for near, the geometric plus in both eyes performs as good as the pairing strategy with geometric and geometric plus. So what does this mean is that when you pair the geometric and the geometric plus, you get a smooth transition from distance, intermediate to near, while having the same distance correction and the same near correction as using the geometric for far only or geometric plus for near only. So when combined, you can see this here, that what is the patient feedback on spectacle usage. When you pair the geometric and the geometric plus, 94.4% are spectacle free for distance, 97% for intermediate, and almost 92% for near. So impressive figures. So more than 90% of patients never use the glasses across all distances. So what is the conclusion of this study? That pairing those both lenses may be used either bilaterally or in a paired contralateral fashion to provide effective correction of presbyopia. So the mean values were 0.15 logMAR with a defocus curve plus 0.5 to minus 3.5. And the concept of pairing these two lenses and not add powers ensures a continuous range of vision from far to close and near. Well, the thing is that the difference between pairing those two lenses and mixing and matching, what is the difference? Because you use the same lens, well, the same refractive index in both eyes, so the same profile, only the light distribution is different. There's the same chromatic aberration, so it's easy for the brain to pick up those images and form one image in the brain and have a binocular good vision. So by pairing those two, you get the most balanced combination for the highest spectacle independence at all distances. Now I will show you a few more complicated cases, because what we see is that a lot of patients we treated on 20, 30 years ago, post-LASIK, post-PRK cases, they come in now because they have reached the presbyopic age and they want to stay free of glasses. So this is the first patient I want to show you. It's a 56-year-old, had LASIK in 2009. It was performed by me for a -2. His best corrected digital visual acuity is still 20/20, but he needs reading glasses. So first, what do? We look at the topography map to see whether the LASIK procedure was nicely centered, that's very important, and that there are not too many higher order aberrations in the cornea. As you can see here, the total order aberrations are 0.14, which is very acceptable to go for trifocal IOL implantation. So almost two years ago, I did a bilateral sequential surgery. The geometric plus 20 was inserted in the right eye and the plus 20.5 geometric in the left eye. What were the results? After 1 month, the monocular uncorrected distance visual acuity was logMAR 0.1 in the right eye and 0.05 in the left eye. The intermediate vision was J3, and the uncorrected near visual acuity was J2. The binocular distance corrected visual acuity was 2020. The patient was very satisfied with the outcomes, and you can be surprised, but he did not report halos, glare, or reduction of contrast. And it's also proven with this device, the higher order aberration aberrometer from CSO, where you can see that there's a very low amount of higher order aberrations in the total optical system. So the patient was very happy with this result. The second patient I want to show you is a 79 years old with anisometropia and astigmatism, and he wanted to be independent after surgery. The best corrected distance visual acuity was, of course, lower because of the cataract, 0.2 logMAR. I did a bilateral sequential surgery, putting in a Vivinec geometric toric plus 18.5 diopters in the right eye, T4, and a 17.5 T3 in the left eye, the geometric plus design. It's of course important to put the lens in the right axis, and therefore I use two devices. First of all, you can see the here the markings in the cornea, which is done by the femtosecond laser. And secondly, I work with a microscope, which gives me a digital overlay where to put the lens. When those two are matching, I'm pretty sure I put the lens in the right position. The Vivinex platform, the Vivinex toric platform, is an established platform, and we know it's the stability, the toric stability is very high. So the geometric it's on the same platform. We also found that this platform is as stable as the monofocal Vivinex toric. What are the results 1 month after surgery? Monocular 0.05 logMAR, intermediate J1, and also for near J2. The binocular distance corrected visual acuity was slightly better than the monocular, 0.0 logMAR, and the patient was very happy with his vision and no glasses needed. Again, we checked for higher order aberrations. As you can see, the post-op refraction, because when you're dealing with those trifocal IOLs, you want to be within half a diopter of spherical equivalent and half a diopter of sphere and less than half a diopter of cylinder. This trace refraction gave me plano minus a quarter at 135 degrees with a low amount of higher order total aberrations of 0.12. We also checked what was the implantation. The astigmatism was corrected in 98 degrees, in the cornea 91. So I could even improve this result by rotating the lens 7 degrees, and I could gain 0.23 diopters in cylindrical power. But of course the patient was satisfied, we did not do it. And the same thing for the left eye, 5 degrees of rotation could improve the astigmatism with 0.16. So in conclusion, we can say that the Vivinex geometric pairing combines two identical profiles. There is no need to identify the dominant eye. You can put the geometric plus in the distance dominant eye or the geometric. The Nino study proved that it doesn't make any difference. Because of the smaller diffractive design, the 3.2 millimeter in the center, there are less side effects and smooth transition for distance and for far and near. I thank you so much for your kind invitation.
Thank you so much, Erik, for a wonderful presentation. I think, this concept of giving more light to near and is really, significant improvement in the concept of giving better, brighter vision to most of them. And looking to your results, more than 92% people are free of spectacles in all distance. That's a wonderful result we have. Just in the meantime, I'll request Namrata to put up the presentation there. One query here, is there any dependence to pupil size? Have you studied the pupil size in relation to the advantage which we have in these patients?
Yes, there is dependency on pupil size.
Yeah.
The thing is, when you have a dim light and the pupil dilates and you get more than 3.2 millimeters of pupil, you end up in the refractive zone of the lens, and that's why we find less halos and glare with these types of lenses. So this is very important to know because we all know it's a trade-off. Multifocal designs give some decrease in contrast sensitivity, but with this design I found less than with other models of trifocal IOLs.
That means we are going to have more benefits in myopic conditions where pupil dilates little more.
Yes.
Yeah. Very good. Any questions to Erik? Thank you, Erik, for being with us, and
Thank you very much.
I hope you enjoyed stay in Delhi. Yeah.
Thank you very much.
You.
It was my pleasure.